Okay, hello again. We're on lecture number 2, part 1 at this point. We are going to be covering getting into analyzing and interpreting rhythms today. So that's going to be pretty fun, pretty exciting. So one of the things that we need to have done prior to coming to this lecture, hopefully, is started to work on committing some of the rules, or I should say rather the criteria for each rhythm to our memory. And this goes back to what I've talked about earlier about sometimes part of understanding the base of it is memorizing facts to begin with. So hopefully we've committed some of those criteria to memory. It'll make everything a lot easier at this point. If you haven't, that's okay. Still got time to work on it, but we got to get on top of that. Okay. One of the biggest things I will say over the years that I've seen was when somebody comes up and says, "Hey, professor, I'm confused about what makes this particular rhythm, this rhythm. Like, why is it whatever you're saying it is?" Okay. So, I'll look at the rhythm and I'll think to myself, like, okay, this is a, whatever, doesn't matter, junctional rhythm, idioventricular rhythm, who cares? So first thing I'll ask the student is, I'll tell them, okay, well, what is the criteria for a whatever, idioventricular rhythm, junctional rhythm, wandering atrial pacemaker, whatever, right? And if they can't tell me what the criteria is, then you never really had a chance to figure out or know what that rhythm was, because the information that you need isn't there. Okay, so what we're going to do today is we're going to try to instill a systematic approach into looking at every rhythm. So there's different ways of approaching it. There's different systematic approaches. You can use the one that I'm going to do. If you have one that you find somewhere else that works for you, by all means do it. If you want to take what I teach you and modify it a little bit to suit your needs a little better, then you do that too. It doesn't really matter as long as you're getting to the goal and not making any mistakes. Okay. So as you can see on the screen here, I know it says interpreting rhythms in a 12 lead EKG. We haven't really got in 12 leads yet, and that's okay. We're going to get there one thing at a time. Okay. Let's start with one lead before we get to 12 leads, right? All right. So like it says, be consistent, be analytical. Absolutely. Okay. You got to memorize the rules for each arrhythmia. You'll hear the term dysrhythmia and arrhythmia. They really mean the same thing. They're used interchangeably. Okay. So don't get hung up on that. What else do we got? So as it says here on the right, interpreting 12 lead EKG. So we got a couple things that we're going to do. So analyze the rate, analyze the underlying rhythm, right? That's what we're going to work on today. Some of the things we're going to look at is analyzing the P waves, the PR interval, the QRS complexes. Okay, these are things that we talked about in the previous video, the previous lecture, all right? Also the ST segments, that's not something that we're going to get into too much right now in this particular lecture. In the future, that's going to be absolutely something that we need to look at, as well as the T waves and the QT interval, and then other pathologies. Okay, so one of the common approaches out there is the RRIAHI, or whatever, as they say. So you check the rate, then you check the rhythm, then you check the intervals, and then you check the axis, and then you check for the presence of hypertrophy, and then you check for the presence of infarction. Okay, so we are not we're on like step 1 of 6 on all of that, so don't worry about all that for right now, but that's where we're eventually heading with all of this. Okay, but to get to step 6, we got to get step 1 down first, so that's the goal today. So let's kind of get right into it. So I'm not going to go slide by slide on the PowerPoint because that doesn't really help for what we're doing right now. Of course, by all means, look at it, and when you're doing your self-study, go over the PowerPoint, go over the video, do whatever works for you. But we're just going to kind of freestyle it a little bit on the whiteboard, and we're going to draw out all of the rhythms, and we're going to talk about, well, we're going to identify the aspects of the rhythm and what makes it the rhythm. If you've already committed the rhythm criteria to your head, then that's fantastic. This will go a little bit easier for you, but if you haven't, then maybe just have it close by so you can reference it while we're doing this. Okay. Hopefully you guys have gotten the Excel spreadsheet that that I made for you guys. All right, so let's go to the whiteboard here. Actually, let me just show you something here real quick before we go to the whiteboard. And let's look at our criteria, and let's actually go to the rhythms here. Let me zoom out a little bit. So, okay. So basically, we can group all of our rhythms into different sections or different types of rhythms. Basically, where they originate from is really what we're looking at, right? So you can have what's called sinus rhythms, okay? And they're called sinus rhythms because the electrical impulse that creates them, that is the impetus for their formation, comes from the SA node, okay? So if the electricity that generates this particular rhythm is originating in the SA node itself, we would call that a sinus rhythm, right? Now there's different, that's like a umbrella category, okay? So there's gonna be different types of sinus rhythms. So you could have a normal sinus rhythm, sinus tachycardia, sinus bradycardia, sinus arrhythmia, things like that, okay? Now, you can also have what we call atrial rhythms, okay? So somebody might say, well, isn't a sinus rhythm an atrial rhythm because the SA node is in the atrium? Well, yes, that is true, okay? But what we mean by atrial rhythms really is we're kind of referring to rhythms that originate in the atria, but not necessarily always in the SA node itself, okay? Because of the property of automaticity, sometimes there are cells that will originate and create electrical impulses when they shouldn't. So I always use the analogy of it's kind of like an orchestra and everybody's playing a musical instrument. And for your electrical conduction to work properly, all of the people playing their instruments should be playing to the same tune, right? They should be playing the same sheet of music. But once in a while, somebody gets their own idea and wants to play their own music at their own pace, and that kind of throws everything out of whack. So that's gonna be kind of like similar to what we see on some of the atrial rhythms. Okay, so things like atrial fibrillation, instead of 100 people playing the same music, now you have 100 people all playing their own individual music. So it kind of gets a little crazy. All right, so your atrial rhythms are going to be things like supraventricular tachycardia, things like atrial fibrillation, things like atrial flutter, wandering atrial pacemaker, multifocal atrial tachycardia. Those are going to be your atrial rhythms, okay? So then we're also going to have a category called junctional rhythms. So junctional rhythms, following the same theme as to what we've talked about, junctional rhythms are going to be rhythms that the electricity that jumpstarts this particular cardiac cycle originates in or AV node or AV junction, okay? So in that case, we would have a junctional rhythm, an accelerated junctional rhythm, and or a junctional tachycardia, all right? Ventricular rhythms, once again, following the same theme, are going to be rhythms that the electricity for this particular heartbeat, this particular cardiac cycle, this originated in the ventricles. So you got to think, if it's a sinus rhythm, where's the pacemaker site of this rhythm? Probably the SA node. If it's an atrial rhythm, where's the pacemaker site for this rhythm? Well, it's probably in the atrium, right? If it's a junctional rhythm, the pacemaker site for this is going to be in the junction somewhere, AV junction. And if it's a ventricular rhythm, the pacemakers are going to be the ventricles themselves, okay? So one of the things that we're going to see is that these different rhythms, sinus rhythms, atrial, junctional, ventricular, they have different characteristics. And we're going to use those characteristics to our advantage to be able to differentiate between the different rhythms, okay? So different types of ventricular rhythms, idioventricular, accelerated idioventricular, and then you have ventricular tachycardia, and you kind of have two different types of VTAC, as we call it, okay? Monomorphic and polymorphic, all right? So those are pretty much the rhythms that we're gonna deal with. We do have other rhythms, and those are kind of what we call the heart blocks. So you have a first degree AV block, and then you have two second degree type blocks. So you have a second degree type 1, you have a second degree type 2, all right? And then you have another one called a third degree block. I don't know who named these or why they named them, but some of these things have multiple names. And unfortunately, you're just going to have to remember them because while I will tell you that most everybody will call it a second degree type 2 block. There will be some people that call it a Mobitz 2 block. And then sometimes you'll hear second degree type 1. Sometimes you'll hear it called Winky block. Sometimes you hear it called Mobitz 1. I don't know why we have 3 names for things, but this is where we are. This is where we are, right? So you just got to learn the names. All right, so those are heart blocks. Now, second degree, third degree blocks technically can be considered rhythms, but a first degree AV block is not necessarily a rhythm. It's something that happens to a rhythm, okay? And what I mean by that is that, you know, if you're in a second degree type 1 block and someone said, well, what's your rhythm? Well, I would say, oh, they're in the second degree type 1. That's the rhythm, right? But if I looked at the EKG and I say, okay, well, he has a first degree AV block. I wouldn't say, if someone said, what's his rhythm? I wouldn't say first degree AV block, because it's not really a rhythm. It's something that happens to a rhythm. So for example, I would say he's in sinus rhythm with a first degree AV block, or he's sinus bradycardia with a first degree AV block, okay? So the things that we're gonna focus on in this video are rhythms themselves. In another video after this, we're gonna focus on things that happen to rhythms, okay? So things that happen to rhythms would be things like premature atrial contractions, premature junctional contractions, premature ventricular contractions, sinus arrest pauses, all of these types of things. So those things themselves are not really a rhythm. They're just something that happens to a rhythm, okay? So I'm a big fan of like organization, especially when you're learning, because the more organized you put things in the brain, the easier it is to pull them back out again. That's just what I've seen over time, okay? All right, so let's kind of get right into it just to kind of show you. This is the chart that I was referencing, guys. Hopefully you've got your hands on it. And if not, then we'll work on getting it to you. So you just got to kind of know these criteria, right? Because what we're going to do, guys, is we're going to approach every rhythm with a systematic approach, and we're going to ask ourselves a bunch of questions, okay? And I'm going to show you what I'm talking about. This is how I approach things, right? I ask myself these questions in this order. And basically what I'm doing here, this is the goal. The information that I gather from asking myself these questions in the top left: what's the rate? Are P waves present? Is there P for every QRS? Is there a QRS for every P? Do the P waves have the same morphology? That's a fancy word for shape. What's the PR interval? What's the QRS width? As in, is it wide or is it narrow? And what's the R to R interval? Is it regular or irregular? Okay. So all those questions is going to give me information about this rhythm. And then what I'm going to do with that information is I'm going to go back in my brain to that chart that I have of all the criteria. And I'm going to say, okay, this is what I got. Which of these things does it match? Okay, so at this point, you're kind of just connecting the dots, all right? So you've got to gather the information first, take the information to the criteria and say, which one of these criteria does this information match? That's how you're going to find out what the rhythm is, okay? So I'll tell you right now, you know, once you've seen a bunch of sinus rhythms, once you've seen a bunch of normal stuff, you can just look at it and be like, yeah, it's normal, okay? But don't get in that habit, because when things get weird, which I promise you they do, and you look at it and you go, oh my goodness, what is going on here? I have no idea what's happening. That's when you need to go back to your systematic approach and start asking yourself the questions, okay? So that's pretty much where we're at right now. So we're gonna go through all of the rhythms that we kind of just discussed, and we're just gonna kind of draw them out, and we're gonna talk about them, and we're going to try to identify what makes them what, and ask the questions, the systematic approach, and all of those things. So just kind of hang on and just trust the process on this one, I promise. So let's draw some stuff out. So if you remember from the other day, we drew a bunch of things, we labeled a bunch of things. So hopefully by now you should be able to identify what a P wave is, what the QRS is, what a T wave is, what the PR interval is, what the QRS width, the R to R interval, things like that. Okay, hopefully by this point you should be able to identify all that. All right, so let's just draw something out here real quick and see what we got. All right, so we're gonna do one more attempt at drawing it more pretty. And if it doesn't look more pretty, we're just gonna have to go with ugly. Oh, maybe red helps too. So what do we got? P wave, QRS, T. P wave really should be smaller than your T wave. P wave, QRS, T, P wave, QRS, T, so on and so forth. Okay, so let's label what we got. P wave, QRS. I cannot write on the screen to save my life. T, all right, so on and so forth. All right, so first thing that we need to do, and like if I'm approaching this, I'm like, all right, what's going on here? I realize, guys, this isn't a strip. You don't have all the little boxes and all the big boxes. So what we're gonna do is I'm just gonna tell you what it is, and then we can kind of just go from there. All right, and we're getting to the point where we're gonna look at real stuff and look at it and count the small boxes, count the big boxes. We're getting there, but let's do this first, okay? So let's figure out what's going on here. All right, so if I told you that this rate was 70, okay, we're gonna say this rate is 70, okay? And how do we calculate the rate? Well, this goes back to the method which we talked about on the previous lecture about determining rate. You can use the 6-second method, you can use the 300 method, you can use the 1500 method. It doesn't really matter as long as you get the appropriate rate. So if this rate is 70, the next question I'm gonna ask myself is, are P waves present? So P, okay? So the next question I'm gonna ask myself, so yes, P waves are present and they are upright. That's important because sometimes they can go upside down. We call that inverted, and that means a whole other thing, okay? So P waves are present and upright, all right? You do have some leads on a 12 lead, which are negative leads. So things are supposed to be upside down. So we're not talking about that right now. We're just talking about lead 2, where things are supposed to be right side up, okay? So next question, do I have a P for every QRS? Well, what does that mean? Basically, what I'm saying is that every time I have a P wave, do I have a QRS that comes after it? So I have a P over here and then a QRS. I have a P over here and then a QRS. A P over here and a QRS. All right, cool. So I have a P for every QRS. Well, reverse that now. Do you have a QRS for every P? So I have a QRS here. Does it have a P wave? Yes. I have a QRS here. Does it have a P wave? Yes. Okay, so the answer to that is yes. And why does that matter? When we start getting into the heart blocks and things, you might not have a Q for every PRF. I'm sorry, you might not have a P for every QRS or a QRS for every P, and that can get into the heart blocks. So right now, let's not worry about that. All right, so do the P waves have the same morphology? So here's what I'm gonna ask you. I'm gonna ask you to pretend that all of these P waves that I drew look exactly the same, because they don't, but pretend for me. All right. So we'll say the P waves have the same morphology, okay? Because if they don't have the same morphology, that gets into some of the other rhythms that their hallmark is P waves that don't have the same morphology, right? We'll get there, I promise. All right, so the next thing I'm gonna look at is my PR interval. So really, guys, what I'm looking at here is that is my PR interval normal or is it prolonged? And remember, our PR interval should be like 0.12 to 0.20, okay? What I'm really looking at is it a prolonged PR interval? There are instances in which you will have an abnormally short PR interval, okay? When you start getting things like LGL syndrome, things that, let's not even get off course, right? But let's just say, are the PR intervals normal or are they prolonged? Well, let's just pretend here. So if I went like this and I told you that this was 4 small boxes, what would you tell me the PR interval is? I will wait. Okay, back, done waiting. So 0.04, 0.04, 0.04, 0.04, that comes up to 0.16. So if we got a PR interval of 0.16 seconds, that would be a pretty much normal PR interval, right? Okay, so QRS width. If I was to tell you that this guy was 2 small boxes, what would you tell me the QRS width is? You would say it's 0.08 seconds. My question is, and what I'm interested in is the QRS narrow, as in less than 0.12, or is it wide, as in more than 0.12, okay? And the reason is that that's going to help us differentiate between atrial and ventricular rhythms, okay? So for right now, let's just keep going. So let's go to the R to R interval. So let's just pretend, for the sake of argument, that all of these R's are the same distance apart. Okay, so let's recap as to what we got. What was our rate? We said our rate was 70, okay? P waves present, P waves are present. P for every QRS, QRS for every P, yep. P waves are upright. P waves have the same morphology, yes. PR interval is going to be normal. QRS width is going to be narrow. And the R to R interval is going to be regular. So if we take that criteria, what we just found out, rate 70, P's present upright, P for every QRS, same morphology, normal PR interval, narrow QRS, regular R to R. We take all of that information, we go to our chart, our criteria list, and we say, well, what does that match? Somebody's going to tell you that matches a normal sinus rhythm, okay? So that matches a normal sinus rhythm, because what do we need for a normal sinus rhythm to be present? We need a rate from 60 to 100. We need to have present and upright P waves. We need to have a P for every QRS. We need to have P waves have the same morphology. We need to have the PR intervals be normal. We need the QRS to be narrow, and we need the R to R to be regular, okay? So let's just work with this real quick. Let's just say, I'm gonna erase some of this stuff. Actually, let's do this. Let's just draw it all over again. And back, there we go. Oh, you gotta be kidding me. That's funny. Let's be careful. There we are. Okay. So let's draw this all over again. Okay. So this time we're gonna have I'm just gonna tell you, we're gonna have a prolonged PR interval. Okay. So we're gonna have a P wave, QRS, T, P wave, QRS, T, so on and so forth. Okay. So let's look at what we got. All right. We got P wave. We got QRS. We got a T. P. QRS. T. So on and so forth. Okay. So let's kind of look at everything we got here. Let's just say, for the sake of argument, our rate is 80. Let's ask ourselves the questions. Are P waves present? Yes, they are. Do I have a P for every QRS? Yes, I do. QRS for every P? Yes, I do. P waves have the same morphology. We're going to pretend they do, and I drew as best as I could. When the P waves have different morphologies, they will be very distinctly different. Like one will be round, one will be upside down, one will be a little wizard hat, okay? And then they will repeat in that pattern, all right? So we're going to say we have P waves that have the same morphology. Now, PR interval. Well, what if I told you that this PR interval was 7 small boxes, okay? 7 small boxes. So what would you tell me the PR interval is? You should say 0.28 seconds. Well, we know that our PR interval is supposed to be 0.12 to 0.20. So that is prolonged. So we would say this has a prolonged PR interval. All right, so QRS, we're going to say, let's just say it's 0.08, which would be 2 small boxes. And let's say the R to R interval, just for sake of argument, is regular. So it's a regular rhythm, okay? So this has kind of all the criteria for a normal sinus rhythm, right? But there's something that's not normal about it, okay? In that case, we have a prolonged PR interval. All right, so if you go to, I'm not trying to get into all the heart blocks and all this stuff right now, but there's a point that I'm trying to make here, okay? So this is a sinus rhythm, okay? But it's not really technically a normal sinus rhythm because there's something abnormal about it, right? In this case, we have a prolonged PR interval, okay? So in this case, we have something that happened to a rhythm. So I would say that this is a sinus rhythm. It's not a normal sinus rhythm, it's a sinus rhythm. In this particular case, it has a prolonged PR interval, which we call a first degree AV block. I'm not worried about you guys knowing blocks just right now. I just wanted to highlight that when something happens to a normal sinus rhythm, it kind of ceases becoming a normal sinus rhythm, because if something's abnormal, it can't be normal. Okay, that's my point that I'm getting at here. All right, so this would be a sinus rhythm with something going on. All right, so let's erase some of this stuff here and keep working. So what did we have? Let's do a kind of a recap. We had a rate of 70 on the first one, rate of 80 on the second one, right? P waves were present, P for every QRS, yep. P, same morphology, yep. PR interval, first one was normal. QRS width was narrow. R to R interval was regular. That fits a normal sinus rhythm, okay? So let's kind of follow the same theme here, but let's look at something that's a little bit different, okay? So if we have some, oh, gotta change the pen. So if we have something that looks like this. Oh, that messed that one up a little bit. What do we notice here? These things are a lot closer together and things are starting to look a little faster, okay? So let's label some stuff here. We got P waves, QRS, T, P. I gotta be honest, I miss the days where I can draw on a normal board in a classroom, because this is really difficult. Okay, you get the point. So let's say we calculated the rate on this one, okay? And the rate that we came up to was 110. Let's keep asking ourselves the questions. Are there P waves present? P wave, P wave, P wave, P wave, P. Yes, P waves are present. And they're upright, okay? P for every QRS. Well, I got a P wave here, a QRS, a P wave here, a QRS, a P wave here, a QRS, P wave here, QRS, P wave here, QRS. Okay, good. And then the reverse of that is true as well. Do the P waves have the same morphology? I tried to draw them the best as I can. Let's pretend that the P waves have the same morphology. So we'll say, yes, they do. Okay. So let's look at our PR interval. Well, let's just pretend here for the sake of argument that our PR interval is 3 small boxes. So if your PR interval is 3 small boxes, your PR interval is 0.12 seconds. Why? Because each small box is 0.04. So 0.04, 0.04, 0.04 is 0.12. So our QRS width, let's just say, for sake of argument, our QRS width is 2 small boxes, and that gives us a QRS of 0.08. All right. Is it wide or narrow? It is narrow. Okay, very good. All right. So where are we at? QRS width. Okay, R to R interval. Very good. All right. So let me move this here a little bit. R to R interval is going to be, we'll say, I try to draw as best as I can, but we'll say this R to this R, this R to this R, this R to this R, this R. We'll say that those are the same distance. If those are the same distance, we would say that this is a regular rhythm. Okay, so let's look at what we got. We got a rate of 110, P waves present, P for every QRS, morphology, same, PR interval is normal, within normal limits. QRS is narrow, and R to R is regular. Okay, so that's pretty much what we came up with when we applied our investigative tools to this rhythm. So what do we do now? We take these tools. We take these pieces of info that we gained from these tools, and we go to our criteria and we say, well, what do we got going on? So if I look at my criteria list and I say, okay, I have something where my P waves are present and upright. I got a P for every QRS. The morphology is the same. The PR is within normal limits. The QRS is narrow. The R to R is regular, and the rate is 110. That means this is a sinus tachycardia. Okay. So what are we seeing? We're seeing a theme here, right? And you're going to see this throughout a lot of the rhythms. So the normal sinus rhythm and the sinus tachycardia, they have the same criteria. It's the same thing going on. There's just one difference. What's that difference? The rate. Okay. So the only real difference between a normal sinus rhythm and a sinus tachycardia, as far as identifying the rhythm, is just the rate. Okay. So you're going to see that theme happen with a lot of different things. So we're going to erase some things here. And we're going to draw another one now. This is the world's smallest eraser. All right. So P wave, QRS, T, P wave, QRS, T, any day now, P wave. Oh, I ran out of room. Okay. So what do we got going on? We got P wave, QRS, T, P, QRS, T. What's the difference just looking at it? There's a whole lot of room between this cardiac cycle and this cardiac cycle. Okay. Well, if I told you the rate was 30, let's apply the rest of our questions. Are P waves present? Yes, they are. P for every QRS? Yes, there is. And the reverse is true as well. Do the P waves have the same morphology? We will pretend. Drawing on a computer is impossible like this, but we will pretend that they are the same morphology. PR interval. Well, what if I told you the PR interval was 4 small boxes? What would you tell me? You would say 0.04, 0.08, 0.12, 0.16. So the PR interval is going to be 0.16. Is that within normal limits? Yes, it is. QRS, let's just say it was 2 boxes. That's 0.08. Is that wide or narrow? That is narrow. And is my R to R interval regular? Well, it would help if we had a third one, but let's just say that the R's were regular all the way across, okay? And if the R's were regular all the way across, we would say this is a regular rhythm. So we'll take all that information that we just gained. Rate is 30, P waves are present and upright, P for every QRS, P waves same morphology. Yes, they are. PR interval is within normal limits. The QRS is narrow. The R to R interval is regular. What does that match? That matches sinus bradycardia, okay? So what do we got going on? We got pretty much the sinus rhythms have the same exact criteria. It's just what's different about them. It's just rate dependent, as we say, okay? So if it's all the same criteria. If it's 60 to 100, it's a sinus rhythm or a normal sinus rhythm. If it's over 100, sinus tachycardia. If it's under 60, it's going to be sinus bradycardia, okay? So now let's look at one that's a I keep doing that. Little bit different. All right, so see what we got here. B, QRS, T, 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 B, QRS, T. All right, so let's ask ourselves these questions. Let's say, for the sake of argument, the rate is 90. It's probably more like 80, but we'll say 90. Are the P waves present? Yes, they are. Is there a P for every QRS? Yes, there is. The P waves have the same morphology. Let's pretend that they do. PR intervals, let's say 3 small boxes. So what is that? 0.12. Let's say QRS width is 2 small boxes, 0.08. Now, let's look at this R to R interval. And this is not just me not being able to draw on a computer while I'm talking to it. But let's say for real that this R to R is that distance. This R to R is that distance. This R to R is that distance. This one is that distance. That's that. And then that's that. Okay. So we have kind of all of the same things that's been going on with the sinus rhythm, right? We have a rate of 90. We have P waves that are present. We have a P for every QRS. P waves have the same morphology. The PR interval is within normal limits. The QRS is narrow, but the R to R is irregular. So the R to R is irregular. So what do we say if R to R is irregular? We say that this is a irregular rhythm, okay? So if you have all the criteria of a sinus rhythm, except for it is not a regular rhythm and you have irregular R to R intervals, we call that a sinus arrhythmia, okay? A sinus arrhythmia. And in this video, as far as just identifying rhythms, we're not getting too much into pathology, okay? But we're gonna do that later. But most common cause of sinus arrhythmia is just respirations. So the respiratory system can cause a brief moment of sinus arrhythmia sometimes. So that's pretty much it for your sinus rhythms. Okay, so let's talk about let's see what we want to do. Let's talk about your atrial rhythms now. And we're going to change the screen. We're not going to draw for right now. We're going to go to the PowerPoint. I know you guys will miss my drawings. I would. That was sarcasm. Okay. So let's find some atrial stuff. So let's find some atrial stuff. So let's talk for right now. So let's look at supraventricular tachycardia, okay? So I'm just gonna use this for example right now. It's just a little bit easier than drawing it out, but we can always draw on the screen. So let's label some things. So this is getting a little tricky, right? Because it looks totally different than things we've been looking at. So let's label some things. So let me get a different color. You got a QRS here. This guy's a T wave. Okay. That's not a P wave. That's a T wave. How do I know it's a T wave and not a P wave? Some people will be like, well, how do I know which one's which? Because P waves come before QRS and that comes before QRS, right? I get what you're saying. But a T wave comes right off of the QRS. So if you really notice, a P wave is not going to come right off the QRS like that, but a T wave will, okay? Once you get used to seeing things a little bit more, you've seen a lot of this stuff, you're going to notice that T waves and P waves look a little bit different. And that'll help you in the future. But for right now, just remember T's come right off that QRS. So what do we got? We got a QRS, a T, QRS, a T, QRS, T, and it just kind of repeats like that. Okay. So interesting. We don't have some P waves. So let's I'll tell you what we can do. Let's find out what the rate is. I'm going to pull my calculator out because I don't know. So I'm going to do it the exact way. And I mean, you could use the 300 method. You could do a couple different things here, right? But I just like to be, more efficient while we're teaching so as to not, make mistakes and confuse anyone. So I'm going to count the small boxes. So it looks like there's 5 small boxes here. And then it looks like there's about 2 more small boxes here. So about 7, maybe you might say 8, but we'll just go with 7 for right now. Okay, so we'll do 1,500 divided by 7. So if we do 7 small boxes, that gives us a rate of 214. If we do 8 small boxes, that gives us a rate of 187. Okay, so we'll just say it's around 214. Honestly, either way, it doesn't change much. Okay, so all right. So let's ask ourselves all the questions. Okay, what's the rate? The rate's 214. Are P waves present? No, they are not. So if the P waves are present, you can kind of skip all the other P wave questions. Like, is there a P for every QRS? Well, no, there's not, because we don't have P waves. Do the P waves have the same morphology? Well, no, we don't even have them to have a morphology. So you can kind of skip the rest of the P wave questions. So what can we ask ourselves next, right? So we can also skip the PR interval, because you have to have a P wave to have a PR interval. Okay. And now we can look at the QRS width. Okay. So this QRS width is really narrow, and that's fine. So it's like 1 box, maybe 1.5, right? So it's between 0.04 and 0.06. Okay. So your QRS, right, is narrow. That's what we're getting at here. And what's left? Let's look at our R to R interval. Looks to me like the R to R interval is regular. Okay. So that's what we got going on in this room. So this goes back to like knowing our rhythm criteria and things of that nature. Okay. So we have a rate of 214. We have absent P waves. Okay. We have a narrow QRS and a regular rhythm. So what we're seeing here is something called supraventricular tachycardia. And the P waves are getting buried inside the QRS, so we're not seeing them. Okay. So supraventricular tachycardia is what we call one of our reentry rhythms. And we're going to talk about some of the pathology in a little bit later in a different video. Okay. So criteria for SVT is going to be a heart rate of greater than 150. Okay. It's going to be a narrow QRS, absent P waves, and a regular rhythm. Okay. So all of that's very important, because if you change one of those things, it could be a completely different rhythm, right? So if I said this rhythm became irregular, well, it wouldn't be SVT anymore. Okay. So criteria for supraventricular tachycardia is going to be absent P waves, because you can't see them. Okay. Narrow QRS, regular R to R, regular rhythm, and a heart rate of over 150. All right. So that's SVT. So that is a atrial arrhythmia. Okay. It's one that we need to worry about, because some of these rhythms are what we call terminal rhythms. In other words, that you just can't live in them for the rest of your life. So if you went into SVT, you'll probably be okay for a little while. You're not just going to like keel over and die in like, 1 second. But you're not going to live the rest of your life at a heart rate of 214 or whatever it was we said. Okay. So rhythms that are kind of like terminal rhythms, they need to be addressed in a timely manner. And that gets into your ACLS protocols and all sorts of other things, which we're not going to talk about today. All right, so let me erase all of this stuff here. So let's talk about atrial fibrillation now. Switch the slide. All right. So you might look at this and be like, oh man, like what the heck is going on here? Yeah, it gets a little weird, you know? So what's happening is an atrial fibrillation. Remember how we talked about the guys playing in the band or the musical orchestra or whatever? So like normally sinus rhythm, everybody's playing the same music in the same timing pattern, and everything's the way it's supposed to be. But what happens in atrial fibrillation is you start getting all of these cells in the atria that start depolarizing when it's not their turn to depolarize. So everybody's kind of playing on their own sheet of music. So what happens when you get electrical like automaticity, when you get electrical impulses that come from different places within the same area, they look differently, right? So if you have a P wave that comes from this part of the atria, you know, it might look like that. If you have a P wave that comes from a different part of the atria, it might look like that. If you have a P wave comes from somewhere else, it might look like that. Okay, so so that's what's happening here, though, is that because we're getting these impulses coming from all different kinds of places in the atria, it starts to look differently. And really what's happening is if you was to actually look at the heart, the atrium is not really pumping effectively. It's just quivering, okay? And it's literally fibrillating. That's why we call it atrial fibrillation, right? So goes back to knowing our criteria, all right? So atrial fibrillation is another rate-dependent rhythm. So basically atrial AFib, is going to be 60 to 100. And if it's under 60, we would call it atrial fibrillation with slow ventricular response, SVR. And if it's over 100, we would call it atrial fibrillation with rapid ventricular response. So some people will say that AFib RVR, rapid ventricular response, is not really until 150, but that's really technically incorrect. We don't really worry about it from an immediate management standpoint until it gets to around 150. But technically speaking, anything over 100 is AFib RVR. So let's look at what we got in this rhythm. So do we have P waves? Well, not really, okay? So these things here, all this stuff, it's just ugly. And you're not really seeing true P waves. You're seeing depolarizations coming from the atria in really no organized fashion. All right, so we would call these non-discernible P waves. That's what we would call it. Just a bunch of nonsense is what it is, okay? So do we have P waves? Well, no, not really. We have non-discernible P waves. Some people would actually call these F waves for fibrillating waves, but that's not a very common terminology, okay? So no P waves, we can skip all the P wave questions, and we can get down to the QRS. So what do we got going on with the QRS? Is it wide or is it narrow? You tell me. I'm talking to myself on a recording, so that's kind of a rhetorical question. So tell yourself, what do we think? All right, looks like about 1, maybe 2 boxes. Okay, yeah, something like that. Yeah, that's what my QRS looks like. Maybe 2 boxes, maybe 1 box, 1.5 box. Either way, it's not greater than 0.12, okay? So we would say the QRS is narrow. So no P waves, narrow QRS. What about my R to R interval? Uh-oh, something is amiss. We have R, 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 and R. Okay, so yeah, that's not the same. So we have what we call an irregular R-to-R interval. So we have a irregular rhythm, okay? So that is a hallmark of atrial fibrillation because what's going on? You got to remember the ventricles take their cue to beat from the atria. That electrical impulse originates in the atria, creates a P wave. The ventricles are waiting on that P wave to tell them to make a QRS, okay? So the problem is that when you have the atriums beating at like 300 times a minute in no real organized fashion, the ventricles get confused. So the ventricles try to match this atrial rate that's constantly speeding up and slowing down. The ventricles just don't know what to do. So they start beating, but they end up beating irregularly because they're trying to follow the irregular impulses coming out of the atria. So that's kind of why you have irregular rhythm. So hallmark of AFib is going to be non-discernible P waves. It looks like that, right? And an irregular R-to-R interval. That is the hallmark of AFib. If it's 60 to 100, it's going to be AFib. If it's under 60, we would say it's AFib with slow ventricular response. And if it's over 100, it's going to be AFib with rapid ventricular response. But like we said, we don't really worry about it till it gets to be significantly faster, right? All right, so let's erase some of that stuff here. So, oh, forgot to erase something. So probably going to make a correction to this PowerPoint, just so you're aware. It says over 150 right here for AFib RVR. I want you to understand, I think that we're talking more about like this particular strip is over 150. I don't think it's saying that, AFib RVR is only over 150. So just kind of keep that in mind. But we might just change that to avoid any confusion. All right, so let's look at what we got. This is a brand new rhythm, and we've got no real P waves, guys. No real P waves. If you have P waves, here's something that might help you a little bit. Unless you have a rhythm where the P waves like look differently, different morphologies that repeat. P waves, if you have them, they are supposed to look like each other, okay? So when you end up having all of this craziness going on, those aren't P waves. Those are fibrillations, fibrillating atriums. So they're depolarizations that are coming out of the atrium that are not in any organized fashion. So let's apply our methodology to figuring out what's going on here, okay? So remember, we have an irregular rhythm, so we kind of need to use the 6-second strip method to estimate our heart rate, okay? So if we go from here to here, so we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 16, 17, 18. We got 18 and kind of almost 19, but it's sort of technically outside of the little hash mark here. But honestly, it's not really going to change too much. So let's just see what we got. So 18 times 10. So we're doing a 6-second strip method to estimate the heart rate. So 18 times 10 is 180. So this heart rate is about 180. If you added that extra one, it's right on the hash. It'd be like 190, 180, 190. But that's not really, we don't need to split hairs or something like that. So we got a rate of about 180. Okay. P waves, well, we don't have them. So that means we can skip all the other P wave questions. What about our QRS width? Well, QRS is narrow. We're going to look at wide QRSs eventually, guys. And I promise you, when you see a wide QRS, you're like, oh, okay, I get it. These are like one box, maybe 1.5. So your QRS is narrow. That's really what we're getting at here, okay? So we got no discernible P waves, a rate of 180, a narrow QRS, and let's look at our R to Rs. Oh, not even remotely the same at all. All right, so we have an irregular R to R interval. So now we just take that information that we gathered, and we have to say, okay, I have something that doesn't have P waves, but it has fibrillating atrial activity. Okay, I have a narrow QRS, an irregular R to R interval, so an irregular rhythm, and a rate of 180. So what criteria does that match? That would match atrial fibrillation with rapid ventricular response, abbreviated AFib-RVR. Okay, so that's what we got here. So that's SVT, and that's AFib, two very common rhythms that you will see clinically. There's a lot of people out in the world that live with AFib. There's not a lot of people that live with SVT because you can't just live in SVT all day long. But there are people that are more prone to tachyarrhythmias that go into SVT more often. It's not uncommon if you have a patient that's in SVT and you take a history on them, and it's not uncommon for this to not be their first time that it's happened, okay? All right, so let's talk about a flutter, okay? A flutter. So we're gonna move back to the whiteboard here. After I erase this. Back to the whiteboard. All right, so a flutter, what's happening in a flutter is that the atriums, so like in AFib, the atriums were just quivering, right? They're fibrillating. So in a flutter, the atriums are beating, but they're literally like fluttering, and that's why they call it a flutter. They're just going like this, fast, 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 okay? Much faster than the ventricular rate is. So we're gonna do our best to draw it out. So if you had a normal P wave, right? P wave might look like that, and you might have a T wave and something along those lines, right? But your flutter waves, they don't have a morphology like that or like that, or whatever. Your flutter waves are going to be more like shark finned, right? Shark finned, or some people say like a picket fence. I always like shark fins because, come on, sharks are cooler than fences, right? So shark fins, okay? So that's going to be the difference between a flutter wave and just a regular P wave. And I know it seems kind of subtle, but when you see them, they definitely have a different morphology, okay? And when we start looking at EKGs, guys, and doing actual practice with strips, you're going to see the difference, all right? So let's draw something out here. Oh man, technology is crazy. I give up. You guys should know it by now. All right, we can talk through it. It's okay. So let's draw. Actually, it's good that it went away. We need to stop using it as a crutch, and we need to put it in the brain by now. Okay, so let's draw something out. All right, so What's going to happen a lot of times, guys, is your T wave is going to get overcome by your flutter wave, okay? So a lot of times what'll end up happening here, let me go back and see if it was on that strip on the one we were just looking at. Yeah, so let me show you something here. So this was a strip of a flutter. And let's just label some things. So these are your QRSs. Okay, so a lot of times what happens with these flutter waves, these are your flutter waves, is that they overtake the T wave, right? And the T wave kind of gets buried under the flutter wave. See, what's going to happen is that we're measuring amplitude. So when two things happen at the same time, the thing that uses more electricity is going to be the thing that you see. Okay, now normally, ventricles repolarizing uses a little bit of electricity. But in the case of the atrium's fluttering, that's going to generate more amplitude than the T wave does. So the T wave is going to get buried behind the flutter wave. It's still happening, right? Things are still repolarizing. You're just not seeing it. Okay, that's okay. So what happens in a flutter is generally you just don't see your T waves. That's important because we need to count how many flutter waves there are because it tells us the ratio of what we got going on. So let's go back. So let's just draw, let's just label everything, okay? So we're gonna just put Fs for flutter waves, okay? So we got one F, and we got a QRS. And you know what? I'm gonna change this to 3 flutter waves, guys. So we're gonna have 3 flutter waves here to stick with the theme. So we have F, QRS, flutter, QRS, flutter, QRS, flutter, QRS, right? So let's just follow along the concept here. So what do we notice that's happening? So we have flutter waves, which is going to make this a flutter, okay? But we need to count the amount of flutter waves that we have because a flutter is going to present a couple of different ways. You might have 2 to 1, 3 to 1, 4 to 1, or variant conduction, okay? So if we have 3 flutter waves, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, we have 3 flutter waves for every QRS, we would say that we have a flutter with 3 to 1 conduction. Okay, so if we had flutter wave, QRS, flutter wave, QRS, flutter wave, QRS, flutter wave, QRS, we had like that. Okay, so what do we got now? We got QRS, QRS. We got 2 flutters, 2 flutters, 2 flutters, 2 flutters. So we have 2 flutters for every QRS. So we would say we have a flutter with 2 to 1 conduction. Okay, you see where I'm going with this? And if we had 1, 2, 3, 4, QRS, 1, 2, 3, 4, QRS, 1, 2, 3, 4, QRS, right? 4 flutters, QRS, 4 flutters, QRS, 4 flutters, QRS. We have a flutter with 4 to 1 conduction, okay? So you count however many flutter waves you got, and you compare it to how many QRSs are in between each one, and you say 2 flutters, QRS, 2 flutters, QRS, a flutter, 2 to 1 conduction, okay? Or 3 to 1 conduction, or 4 to 1 conduction. Now, what if you had something look like this? Flutter wave, QRS, flutter wave, QRS, flutter wave, QRS, flutter, QRS, flutter, QRS, flutter wave, QRS, right? Because this happens too, all right? So we've got 2 flutter waves, a QRS. We've got 2 flutter waves, QRS. We've got 4 flutter waves, a QRS. got 2 flutter waves of QRS, 3 QRS, 2 QRS, 4 QRS, so on and so forth. So we have a different amount of flutter waves for every QRS. We would say we have a flutter with variant conduction. Sometimes you might hear the term a flutter variable conduction or a flutter variant conduction. It's all the same thing, just matters on the words, okay? They're just words. They're just words. All right, so that is a flutter, and that is the a flutter conduction ratios. So what I will tell you is let's go back to our PowerPoint here. So, well, let's go back. What do we got? You know, let's draw. Annotate, draw, 2 flutters, QRS, 2 flutters, QRS, 2 flutters, QRS. So we would say we have a flutter with 2-to-1 conduction, okay? So here's what I'm going to tell you as far as the QRS should be narrow. Your PR should be normal. It should not vary, right? I mean, it can, but it's usually normal. It can go either way. Your rates are going to really just depend. So like the longer conductions, it's harder for them to get tachycardic, right? Because if you have 4 flutter waves in between each QRS, it's just simply going to take more time for those flutters to occur, which are going to push the QRSs farther apart from one another, which will make this rhythm a little bit slower. So you usually see the faster A flutters in like A flutter 2-to-1 because you don't need as much space in between those QRSs, okay? So A flutter 2-to-1s can present with a little bit higher rates, getting 150s and up ventricular rate. That can, that's where you start getting into problems. What I'll say though about the R to R intervals, guys, is that generally speaking, A flutter it just depends. So A flutter 2-to-1, 3-to-1, 4-to-1 are pretty much going to be normal R to Rs. So 2-to-1, 3-to-1, 4 to conduction is generally going to be a regular R to R interval. However, variant conduction, because you have a different amount of flutter waves in between each QRS, right? Because kind of like the thing we just drew out with the irregular one. With the variant conduction, you're going to see that you get irregular R to R intervals because you have a different amount of space for a different amount of flutter waves in between each R wave, okay? So that's pretty much where we're at on that. So what else do we got? Let's just finish up our atrial rhythms, guys, and then we'll take a break from this video, okay? So there's 2 more atrial rhythms that I want to talk about. And honestly, they're like the same thing. So we can almost like kind of kill 2 birds with 1 stone in a sense. I have no idea whoever came up with the saying of kill 2 birds with 1 stone, because like, what kind of a monster are you? Like, why would you want to kill birds with stones? Like, that sounds like terrible. Who does that? It's terrible. Crazy, ridiculous. All right. So let's go back to the whiteboard. All right. What are we doing? Let's do, well, let's draw it. I'm not going to tell you. It'll be a surprise. Do my best to draw now. So P wave, QRS, T, upside down P wave, QRS, T, wizard hat P wave, QRS, T, artifact, wizard hat, QRS, T, upside down one, QRS, T. Okay, so what do we got going on here? Got some funkiness going on with our P waves. Let's ask ourselves the questions. Let's say, for sake of argument, the rate is 80. Okay. So first question, do I have P waves? Yes, I do. That's a P wave. That is an upside down P wave. That is a P wave. That's a little wizard hat. And that's an upside down one. Okay, so we have P waves. All right. Do I have a P for every QRS? So P, QRS, P, QRS, P, QRS, P, QRS, P, QRS. Yes, I do. And QRS for every P. Yes, I do. So do the P waves have the same morphology? So this is not an example of me not being able to draw on a computer. This is real life, different morphologies. Okay, so we got kind of a normal one here. We've got a upside down one here. We call those inverted P waves is the proper term. Okay, got a tall one over here. Got our little wizard hat over here. We've got our upside down one again over here. Okay, so we have P waves. They have more different morphologies. Specifically, though, they have 3 or more different morphologies. If this was a long strip and you could like read it out for a while, you would see that these patterns would repeat themselves. Okay, it's not just like going to be like an infinite random number of weird looking P waves. It'll be like 3 or maybe 4 of the same type of ones that repeat over and over again in their individual patterns. Okay, so PR intervals, we'll say 4 small boxes, so that's 0.16. QRSs, I kind of had a little hard time drawing on the computer, but we'll say they're 0.08. And had a little bit of hard time drawing it, but let's say the R to R, for example, is not the same distance. Okay, so let's just say that we have an irregular R to R interval. So let's look at what we got. Okay, we've got a rhythm whose heart rate is 80. P waves are present, P for every QRS, but our P waves have 3 or more different morphologies. That is an important term, okay, because that's going to be pathognomonic for wandering atrial pacemaker and multifocal atrial tachycardia, okay? In this case, we have a narrow QRS and an irregular R to R interval, which means an irregular rhythm, okay? So what does all that mean? Here's what I'm gonna tell you. Wandering atrial pacemaker and multifocal atrial tachycardia, their hallmark is 3 or more distinct individual morphologies of their P waves, 3 or more different morphologies of their P waves, okay? The only difference really is that wandering atrial pacemaker is going to be, oops, less than 100 beats per minute. Multifocal atrial tachycardia is going to be greater than 100 beats per minute. It's like the same thing. It just is rate dependent. So if this exact thing was a rate of 80 or 90, wandering atrial pacemaker. If this exact thing was a rate of 110 or 120 or whatever, then we would say multifocal atrial tachycardia, okay? So you're gonna see that there's a lot of rhythms that it's just like the same thing. It just depends on what the rate is, okay? So not something that's very common in 15 years of medicine. I think I've seen like I've seen like two or three MATs and like 1 or 2 wandering atrial pacemakers. They're not common, okay? Most common cause multifocal atrial tachycardia. It's gonna be pulmonary problems, specifically like COPD. They always love to put that on tests somewhere. I don't know, it always shows up. So that is wandering atrial pacemaker. That is multifocal atrial tachycardia. Okay, things that we need to talk about in the next video are going to be junctional rhythms and ventricular rhythms, and then of course things that happen to rhythms. But for right now, we're going to end this video. I think we accomplished a lot of things. We got the basics down. We spent a lot of time identifying, or how do we say? We spent a lot of time getting our process down. We want to have the right approach, okay? And that's very important. You got to have a systematic approach to these things. So once again, if you want to use like the questions and the formats that I gave you, by all means do it. If you want to modify it to your own needs, that's fine too. If you find something online you like better, you can do that. As long as you're getting the proper information and then applying it to the criteria. If you haven't learned the criteria for all these things yet, you've got to commit that stuff to memory, okay? This cannot work without committing that to memory. All right, so once again, if you guys have questions, by all means, please reach out. We'll do the best we can to answer them, and try not to move on with unanswered questions, okay? All right, so thank you as always, and we will see you on the next video.